Well, thank you for joining us for the final edition of the RNAO's Best Practices in Oral Care for Long-Term Care Home series. My name is McDonald, and I'm the RNAO Long-Term Care Best Practices Coordinator within the boundaries of the Champlain LHIN. The presentation today will focus on best practices in oral care at the end of life. And we have Suzanne Jensen joining us today as a presenter. She's a registered nurse, pain and symptom management consultant who supports regulated healthcare providers at the bedside of patients and families receiving palliative care. Before we review some housekeeping points, you may be joined by either phone or either voice or internet and have been placed on mute. When we get to the end of the presentation, you have two ways of being able to ask questions. With everybody, you can ask over the phone, or you can do on the right-hand corner on your screen. And we'll either ask the most frequently asked questions or allow individual questions. Please, this session is being recorded and archived for future viewing. Again. Here we are. Here's Suzanne and Ivo. You look lovely. Just for the presentation. It is hoped that participants will understand the importance of providing oral care and performing oral assessment at the end of life when managing oral health issues in order to improve residents' comfort and quality of life. The focus is on pain, comfort, and symptom management, which is our second objective, for staff to be able to recognize some of the common oral conditions that affect at the end of life, and that they will consider appropriate interventions in the residents and families with. Finally, discuss and explain oral care practices that are not recommended at the end of life.
Suzanne here. Care goals. Oral care is an indicator of overall health and well-being. You know that by just looking at the oral mucosa, the purity of it, the color of it, the level of moistness in it, is actually a good indicator of a person's overall health and well-being. Good oral care, first and foremost, we're looking at improving a resident's comfort. Good regular cleansing and moisturizing of the oral mucosa, you can actually improve that person's quality of life. With going to avoid the risk of complications such as oral infections. And several different problems that a person can develop in the oral care. And some do have pain associated with it, and others do not. By understanding the underlying etiology of what we're seeing for the patient, the family, and care team will help that patient and family take part in that oral care regime and in bedside care. As goals of care are identified by the first patient and the family. That individual will want to take into consideration any cultural or personal beliefs about oral care when doing that overall care planning. The duality is extremely important.
Oral care is one of the basic requirements that residents need in terms of personal care. However, it needs to be carried out consistently. If not, oral diseases and poor oral health will result. This outlines the basic oral care techniques that are recommended for all residents. The first oral debris cleaning technique, which is used prior to brushing the resident's teeth. This entails is taking 2 pieces of moistened 4x4 gauze, wrapping it around your gloved index finger. You sweep the gauze from the back of the mouth to the front of the mouth inside the buccal fold, so that it's between where the tops of your cheeks and your gums meet. The purpose of this is to remove the debris and the food that become trapped outside as a result of residents not being able to manage this area due to poor and weak facial muscles. I have a small little video that I'd like to show you right now that demonstrates this technique. No, it's not the great quality, but at least it allows you to see what this would look like. And notice well the amount of debris that actually comes out of this resident's mouth. It's not an uncommon finding to find debris in here. It's essential to remove any debris in the mouth, as it results in increased bacteria counts, bad breath, and can be a risk for aspiration. So I'm just going to go to the video. Oral should be done at least twice daily using a soft toothbrush with only a pea-sized amount of toothpaste. Brush for 2 minutes. Ensure that you brush all surfaces, so the outsides of the teeth, the insides of the teeth, as well as the bite surfaces are on top of the molars. Adding oral care, please ensure that the mouth is left moist and includes the lips. Encourage residents to stay hydrated by taking sips of water throughout the day. So whenever you're in the resident's room, encourage them to take a sip. Anybody who goes into the room and leaves the room, encourage them to take sips of water. Resident preferences and abilities in cooperating with personal care. Use different techniques such as bridging, mirroring, 2 toothbrush technique, or 2 people to ensure that oral hygiene is provided. Any oral care provided to residents will fail in the long run if adequate and regular oral care is not provided.
By ongoing discussions with the resident and the family about what their preferences and wishes are, the care for this symptom is paramount importance. By involving the family, we will get more compliance and involvement with the patient's bedside care. Knowing the patient's wishes and goals, again, what is important to that patient. I remember a patient whose family said, "Mom always wanted her lipstick on." That was one of the cultural importance for that family. They wanted their mom to look like their mom. Actually got written into the care plan. Number assessment of the oral cavity. You cannot do a thorough assessment of the oral cavity without a light. This is the message I want you to take home today. Get a light. As Ebo said, sometimes 4 hands are required to do a good assessment. So tap your colleague at work to doing this good comprehensive assessment. Different oral care products differ across different long-term care homes. Available in one may not be available in the other. We're going to give you a few examples of what products can be used in an oral care basket of care.
Not in terms of assessment of the oral cavity. When you're providing care, that's an opportune time to take a look in the mouth. So take the opportunity and assess on a daily basis, because as these changes in the mouth, they can progress very quickly, and you want to identify it as much as possible. You also ensure that you use a detailed oral assessment. That could include the RANDS, but also using a standardized tool such as the OHAD or the Oral Health Assessment tool could be a consideration so that you can track changes over time.
As mentioned earlier, not all oral conditions are painful. So underlying etiology is important to developing that plan of care. By complete and thorough comprehensive assessment of the oral cavity, you'll be able to determine what the problem is for your resident. And in long-term care homes, there are many residents who are not able to self-report pain. They can ring a bell, nurse or the care provider what is wrong, and ask for medication to alleviate this discomfort. So we rely upon assessments that are validated, standards may be incorporated into your care home, and shared amongst the care team. Not all pain scales are required to be done by a regulated care provider. PSWs can certainly be involved in doing these kinds of assessments under the mentorship of a regulated care provider. We're showing an example of the Abbey Pain Scale, which you may be familiar with. We're looking at a resident in 5 different parameters of behaviors or indicators might be triggered by discomfort or pain. So we had things like negative vocalizations, present or not present. Is patient whimpering, groaning, sighing, crying, or negative terms like no, go, help. Facial expression parameter, we're looking at what that person's facial expression looks like. Is it tense? Are they frowning? Is there grimacing evident? Are they frightened when you approach them to provide care? The body language. Do you see that fidgeting or restlessness or rocking garden area that they don't want you to touch? Are they drawing from you when you approach them to provide care? Behavioral and psychological change. We're looking at a resident who may have change in their cognitive status. Are they more confused than they normally are? Are they refusing to participate in activities that they normally would do? Is there a change in their daily patterns? These families can be a great resource. They'd be the first ones to say there's something different about mom today. In parameters, we're looking at changes in vital signs, which may not be helpful at times. And then lastly, is there any physical alterations? Skin integrity, pressure areas, and other things. To the PainAD tool, and looking at much the same type of parameters in breathing independently, negative vocalizations, facial expressions, body language, and what they've added here is consolability. If the resident is easily consoled or there's no need to console, then they're scoring on the lower parameters. With these tools, you will get a total score. Depending on the higher the score, would be more indicative that patient could be experiencing pain. Again, having a quick glance at two tools that are available. There are many available, and it may not be the ones that you are using in your residence. Ask your care team which tool they're using to assess pain. Problems that we often see at end of life are dry mouth, lips, cracks at the corner of the mouth, which is called angular cheilitis, or candidiasis, problems, difficulties, and fitting dentures. I have a picture in front of you that is evidence of early stages, or stage 1, xerostomia, or dry mouth. In mouth, the oral mucosa are pink and mixed in appearance. You see less saliva or thick, ropey-looking saliva. The oral tissues will actually be so dry that when you examine the patient, your fingers in a glove will stick to the mucosa. To treat dry mouth include saliva substitutes, sugar-free candy. There is a trade name called xylitol, which can be fairly costly to patients and families, sugar-free gums, and free sipping of water and or ice chips if the patient or resident is able to tolerate that. Angular cheilitis are painful, whereas xerostomia or dry mouth is not painful, it's just more of an irritation. A person who has breaking in the skin or these deep cracks at the corners of their mouth or lips can be very uncomfortable. To treat water-based lip balm or moisturizers, increased oral hydration is possible, and consider using a cool mist humidifier in the room. Of water-based lip balms or moisturizers, you will find them under the trade names of Biotene products, a moisture spray or lubricant, as well as the Glaxol base, which is a water-based, water-soluble product. However, it does break down easily and needs to be applied more frequently. There's also water-based lip balms that are available. Or oral thrush is painful for most patients. However, in a very advanced stage, it can become quite painful. And the red flag, or the indicator that can actually identify thrush, it appears as a thick white coating on the tongue. When you go to clear or clean the mouth, that patch doesn't wipe away. It remains there despite oral care. The end of the white patch can be quite red and inflamed looking. Oral thrush earlier is very important. So if you are seeing this and you are in doubt or not sure of what you're seeing, go to the care provider and get someone to take another look at that patient's mouth. By providing intervention earlier, the thrush infection will clean up and be cleared much sooner rather than later. It can become quite distressing for the patient, affecting overall appetite, loss of appetite, discomfort, even social impact. So look at treatment. The physician needs to prescribe an antifungal agent. Most commonly used is nystatin, as a chlorhexidine diluted solution, which can be used to cleanse the mouth. Remember, if we are treating an oral thrush, that we have to take into consideration of treating the dentures as well. If we cleanse the dentures and apply a few drops of the nystatin solution to the dentures, then we're constantly reintroducing the infection into the oral cavity.
When swallowing problems at the end of life, we're referring to residents with a PPS of 30 or lower. This means that a dietitian or a speech-language pathologist likely would have already been involved in swallowing issues if they were identified sooner. Signs and symptoms they'd be looking for: coughing or choking, weak or throat irritability, and pooling or drooling of the spit or inside the mouth. Some causes of swallowing problems could be Parkinson's, stroke, or advanced dementia. It can occur as a result of dry mouth or lack of saliva, which makes it more difficult to move food or debris around in the mouth. It's that at the end of life, it's a normal part of the dying process that the resident will not be eating and drinking normal amounts, and they're not distressing to the resident. Family members can associate decreased intake with weakness or become weaker, sick, or pain. For example, a family member could say something like, "It'd be painful to become dehydrated because the body needs a certain amount of water, which will make them sick." The quality of life by supporting residents and families with their wishes. You will relieve pain and any symptoms associated with dry mouth and improve safety to reduce the risk of choking or aspiration while providing oral care. Techniques for dealing with swallowing problems and oral care is to use the moisten gauze technique to remove debris and address the dryness that we showed you earlier. Using a suction toothbrush could also help to reduce the risk of choking or aspiration, but it should be noted that suction toothbrushes do not always get enough suction with most portable suction machines. Products, especially toothpaste, are not appropriate for residents with swallowing problems. The action increases the flow of saliva and increases the risk of choking. What you should be using with that is just a little bit of water in order to, when you clear the mouth. To educate families and staff about the reduced intake, as this is a normal part of the dying process. So dentures. So there are two areas that you want to consider. The denture itself, does it fit properly? You assess this by taking your two index fingers when the denture's in the mouth and putting them on either side and rocking them back and forth, so kind of where the molars would be. If there's a lot of motion rock on the top of the mouth, it means these dentures are not fitting properly. That significant weight loss does affect the way that a denture fits. Look at the dentures themselves to see if there's any damage or warping that could be causing problems or pain in the resident's mouth. So here's some pictures you can see of very damaged dentures. It's not typical disease, but I wanted you to have an idea of what a really bad looking denture would look like. The second thing you want to look at is the oral cavity itself. So again, coming back to that, looking inside the oral cavity, pulling back the cheeks, looking inside. Is the denture affecting part of the mouth? Is it causing any sores or ulcer spots because they don't fit well? So as we discussed, if you notice any problems with the oral tooth, report and use appropriate interventions to alleviate the symptoms. No wishes and preferences of the residents and families around dentures. Perhaps a resident would not want to be seen without dentures. So cleaning these dentures and putting them back inside the mouth would be very important for that. However, when residents are no longer able to keep those dentures in their mouth on their own, it is recommended to take them out as they're a choking hazard. During infections. When infections in the mouth, it's very important to continue to keep up with the basic oral tech mentioned earlier, and the proper oral hygiene is taking place. You may need to increase the frequency of oral care to ensure that you're getting rid of the bacteria that's causing the infection. If a mouth rinse was prescribed, such as nystatin, you'll use this as indicated. If the need to use a toothbrush due to pain, use the 4x4 gauze technique mentioned earlier, or try switching to an ultra soft toothbrush, as the oral cavity is very important during infection. If a question that that comes up sometimes is if you're not comfortable using the 4x4 gauze technique, what can you do? Well, you need to be able to get in there. So if an ultra soft toothbrush is not available, don't just use a regular toothbrush because it could actually cause more damage because it's not soft enough. So if the mouth is dry and you're trying to get in there with that toothbrush to try to clear those pockets, it could actually cause damage. So it's best to use the softest material possible. If toothpaste is hurting the sensitive oral tissues, you can switch to using the bland mouth rinse. And the way to prepare this is you'd use 1 tablespoon salt, 1 tablespoon baking soda, and 4 cups of water. You'd prepare daily. It doesn't need to go in the fridge. You just mix it up, and it's good for 24 hours. Please remember to replace all toothbrushes after any oral infection.
Oral or mouth care. At end of life are not eating and drinking well. Care becomes one of the primary comfort measures to provide our residents. Skin and oral care become the every 2-hour routine for a person end of life. You need to understand the basic etiology of the dying process, that to interfere with this, with artificial hydration and nutrition, can cause more problems and more discomfort to residents. So understanding that it is a normal, natural dying process, and hands-on oral care and skin care are what contribute to the patient's comfort. End of life, we are probably not using toothbrushes. We use the moistened gauzes to sweep across the tissues and the teeth. An extra soft toothbrush, we're contributing to maintaining the integrity of the mucous membranes in the oral cavity. Involved in this care plan is the paramount importance. With that, we're looking at goals of care as identified by the resident family, providing care. At the end of life, the person is not conscious. So by putting the resident onto their side when providing oral care, is appropriate placement for patients when intervening with this type of care plan.
Example of one home's oral care bins they made up. So they have toothbrushes, disposable cups, dilute mouthwash, 4x gauze, Mucogel, lip chap, so a lot of substitutes and gloves. And if they just take it out and put it within the resident's room.
Items not be using when providing oral care. The steps that have become extremely popular over the years do not follow under best practice guidelines. We probably all walked into a resident's room and seen a collection of these two sets sitting in a glass of water. And after time, the pink sponge can actually come off of the white stick. Initial intention of these products were meant to be a single-use product where they were moistened and the oral tissue, and then they were disposed of. Unfortunately, they've become more of a hazard than aid. Lobs as well have fallen off the radar. Know that they are quite acidic and can cause discomfort to the oral mucosa when there's any break in the integrity. Alcohol-based mouthwashes should not be used as they dry out the oral mucosa. Can cause foaming and a person who's not able to swallow can be at high risk for aspiration. So we don't use toothpaste at the end of life, or if there are any indicators of dysphagia, swallowing, or any altered oral tissues. Toothpaste can be quite irritating to the mucosa. The blend rinse needs to be made up daily. It can be kept cold or kept at room temperature. Room temperature is the recommended way of providing this. Also, lip balms that are beeswax based can be used and are recommended to use. And lastly, in the do not use category are petroleum based products. So who's receiving oxygen and combined with a flammable petroleum based product is not recommended. So back to the water based things like KY jelly, black soul base, moisture spray, are all water soluble and to use rather than petroleum based products. And hydrogen peroxide comes up every time, and again, that is not something that's recommended for oral care at end of life.
Hydrogen peroxide is actually used as a whitening agent, so it is very harsh. So you don't want to be putting that into someone's mouth end of life who's having any issues or pain. It's not recommended. And another thing with the tooth access, the reason they're not recommended is that the evidence is showing that they don't actually take anything out of the mouth or off the teeth. It just moves around the debris, and that's the reason why they're not recommended to be used, as well as being a choking hazard.
For resources, if you go to www.cancercare.org, you will see the Cancer Care Ontario Toolbox or Guides to Practice. There are several different pocket guides and algorithms, and the oral care section will give you lots of resources on providing oral care in end of life. Virtual Hospice website, you can go there to find lots of information about hospice and palliative care, and you can actually type in a question and you will get a response in 24 to 48 hours from a professional. Care of the Dying from Victoria Hospice Society is a great resource.
Resources, here are just two. So there's the best practice guidelines themselves. So if you're interested in finding out any more information on oral care, this is a great avenue to go to. There's also the oral assessment series. So if you're not too comfortable or not too sure on what you should be assessing for, there's 3 parts to this. So the first part is, what is the normal mouth and what does it look like? Part 2, what is abnormal? What are some common things that you can find in your residents? And part 3 is interventions that you can do in house and long-term care. I say that we will be rerunning this 3-part series later on in the summer, so stay tuned for that. And if you're interested in implementing the best practice guideline on oral health at all, just speak with your long-term care best practice coordinator. I'm sure they'd be happy to help you with that. So for the images that we use. So to the end of the presentation, I'll now unmute all the phone lines and the voice over internet for any questions. I would like to thank Ken Jensen very much for participating and helping us with this presentation. I'd like everyone to take 5 minutes to complete poll to help us to evaluate, and thank you very much for listening. So the questions that have come up, we had someone ask, can you give examples of water-based moisturizers and lip balms?
In Guide to Practice, we're looking at products called Moisture Spray, or Biotine is a trade name product, and they have different formula in the market, as well as Glaxol base or Derma base, otherwise known as KY jelly, or Glal based products as well are water based.
We have red available are those little tubes that you use for suppositories. Those are water based. So just to know again about water-based lubricants for the lips, they do evaporate faster than the petroleum-based ones, so you do need to reapply them a little more frequently. We had come up, is I don't feel comfortable putting my finger in the resident's mouth. Is there something else I can do without putting my finger in? I know with this, but we're not asking you to put your finger into their mouth. We're asking you to put your finger just gently between the teeth and the cheek, so it's not inside. If you do feel like that there might be a risk for biting, you can use the other side of the toothbrush, so the bristle side, the other side to place it just gently between the teeth to make sure that they don't bite down. But it's really important that the oral care does happen. So the way to be able to get rid of that debris is important, and the gauze technique is a really easy technique. And someone was asking about other types of solutions. So we mentioned the bland solution. We did about peroxide rinses, that they're not recommended. Sometimes people like to use a diluted version of mouthwash. And just about mouthwash is that they're tested a specific way. They're made for a specific strength. So if you're diluting it, you're not really using it for the purpose that it was designed for. And then when we come back to talking about end of life, I'm not really sure how harsh mouthwash is what you want to be using anyway. So again, maintaining that comfort and using the saliva substitutes and moisturizers to keep mouth from drying out and maintaining that comfort end of life is what's really important.
Reflect for just a moment. The first thing we do in the morning when we get up or before we go to bed at night is brush our teeth, and how good and fresh that feels. So taking that into consideration, knowing that we can provide that kind of freshness and comfort to our residents, brings the point of how relevant oral care is.
We have time for one more question. There's a question here about what can I use instead of toothpaste? We talked about not using toothpaste. When it comes to the resident with swallowing problems, again, you don't want to be using the toothpaste because it's a risk for choking. Just using a little bit of water and using that Gauss technique to swipe out the mouth. What about dementia residents? The reason for dementia residents not using toothpaste is that the strong taste usually affects their ability to cooperate with oral care. So there are some low foaming options out there, and there are some other options with different tastes that you can experiment with until you find something that might work. And you could try just using a plain baking soda one, although that doesn't really taste good either. But the purpose of toothpaste is the fact that it does have a small abrasive quality to it that helps to remove the plaque from on the teeth. So that's why you want to use a toothpaste. Okay, everybody, that brings us to the end. Great day, and thanks for participating.